Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right, guys. So I welcome one and all, especially Pavitra, who's going to be our presenter for the case tonight. And over to you, Pavitra. We can start the case discussion now.
Yes, ma'am.
Most of the students are there, and as we speak, they'll join in. Okay. So can you see the slides, Pavitra?
Yes, ma'am.
All right. So we begin with the discussion of ectopic with Pavitra, and here's your first slide. Yeah, please go on.
Patient Mrs. Gayatri, wife of Mr. Erum, 30 years. Her education status is 10th standard. She is a homemaker by occupation. She is residing at Ramnadu. She is married for 2 years and she is a primary gravida. Her last menstrual period is 19/5/25 and her expected date of delivery is 26/2/26. Her gestational age is 7 weeks. She came with the complaints of abdominal amenorrhea for 7 weeks and abdominal pain for 2 days and a history of spotting TB for 1 day.
Okay. All right. So just by this, okay, because now you're going to be taking her history further. These are the presenting complaints. That means history of amenorrhea along with pain abdomen along with spotting PV. Okay. So what is striking in your mind? What DDs are you thinking of?
Threatened abortion or any miscarriage.
Yes, definitely. One
Delayed
could be.
menstruation.
Sorry.
Delayed menstruation.
Delayed menstruation. Very good. Very
Yes.
well done. Yes. Very good.
And the
Definitely.
property of,
Isn't it?
yes, ma'am.
Then anything else?
Any local causes of
Yes, local
trauma,
cause of pain and abdomen and maybe yes. Go on.
Any causes regarding the UTI.
I think we can hear your voice, but it's a little, kind of mumbled. It's not clear. The voice is not clear.
Can you hear me, ma'am?
Yeah, this is better, I think. At least it's, kind of clear, but the decibel is low.
Can you hear me, ma'am?
Yeah, this is better. Yes, please tell me.
Yes, any causes regarding UTI?
Yes, any local causes. It could be appendicitis, it could be ovarian torsion, it could be UTI, it could be ureteric colic. So these are non-gynecological causes, possibly a reason for ectopic. Possibly a reason for the pain abdomen. And bleeding could be just because of, but then she has also amenorrhea. That could just be a delayed period, or maybe she has early pregnancy with these kind of features, isn't it? Why can't it be early pregnancy with one of those features? Corpus luteal cyst, ovarian torsion, appendicitis, ureteric colic, UTI. Correct? So these could be, yeah. These are the DD that's running in your mind. You're not narrowing it down to ectopic pregnancy, and this is the problem you have, all of you, in the exam. You go ectopic minded and you don't even think about anything. So this question, when it comes to you, you suddenly, thrown from your game. You went thinking, oh, my case is ectopic pregnancy. I will speak the medical management this, the surgical management this, the expected management this. These are the criteria and everything. That's pretty later. Your impression gets spoiled when you do not think of anything else apart from ectopic pregnancy. Do not be completely your case minded. The case can go in any direction if the examiner wants it. So do not fumble here. DD should be the first thing. See, I always ask DD immediately. Okay, though this is not a very, standard way to place for anybody to ask, but this is actually how your thought process goes. You are giving me the history that she came to us with complaint of amenorrhea in the past 7 weeks, along with abdominal pain, along with bleeding PV, and now I'm asking you what is going on in your mind? What are you thinking? So you have a DD in your mind because of which you will now ask questions related to it, and you will start, striking those points that no, this doesn't look like that. This doesn't look like that. This doesn't look like that. It's probably narrowing down to ectopic, and that's how you arrive to your diagnosis. Okay. All right, guys. Moving on. So these are the DDs that is coming on your mind. So based on that, now you've done with the chief complaints. Now you'll ask about the history of presenting illness, trying to understand where we are going from here. Yes. Yeah, tell me please.
Patient complains
Hmm.
of abdominal pain for up to 2 days. History of
Yeah.
spotting pain for 1 day. Over the right, pain for the right leg force. Pain is not radiating. History of spotting PB for past 1 day. No history of urinary complaints. History of any passage of clots. No history of post-smelling vaginal discharge. No history of any fever.
Hmm. Okay, now see, when you're describing the pain, whenever you're describing any pain in the last class also, be very sure that the pain has to be described properly. That means site of pain, duration of pain, nature of pain, radiation of pain, aggravating and relieving factors, since when the pain has been there. Okay, this has to be spoken. So all these things have to be spoken about the pain. So please now describe it again, Pavitra. What was the pain like?
Pain is over the right iliac fossa region. It is gradual in a dull aching pain, gradual in
Okay.
onset and progressive nature.
Okay. Since
There
the
is no
past 2
any
days. Okay, no aggravating,
past
relieving factors.
factors.
What about bowel and bladder motion? Any movement, bladder movement, bowel movement is associated with it. Why am I asking this? Is because if it's any abdominal cause, it will reflect in your bowel motion as well as your bladder motion. If it's ureteric colic, maybe you're having hematuria, maybe you're having burning micturition, maybe you're having pain during urination. And if it's a ovarian cyst, appendicitis, might be you'll have diarrhea, constipation, or pain in passing motion. Could be anything, right? So,
There is no
any
complaints of any urinary or
sorry,
there is no complaints of any urinary or bowel symptoms
bowel
with the
motion.
patient.
Okay, and the pain is non-radiating. Okay, agreed.
Yes, ma'am.
Has she taken any painkillers for that?
No, ma'am, she had not taken any painkillers, ma'am.
That means the pain is not all that severe. Should I say that?
Yes, ma'am.
All right. So there is pain. She has come to us with pain. It's a very important, the thing in ectopic pregnancy. Can you tell me why is pain a very important factor in ectopic pregnancy, Pavitra?
In case of ruptured or unruptured ectopic, it can be able to differentiate.
Actually, pain is one of the reasons based on which we will take our further management. If she's in pain, why will we give a medical management? Maybe she's having impending rupture. Impending rupture will not come in ultrasound also. Impending means it's not yet happened, right? Only thing that will differentiate it will be the pain of the patient, the subjective pain of the patient. So if she's in pain, you have to be very sure of giving her, medical management, because you're taking a risk in her. Okay,
Yes.
Right. So pain is important. Now I've told you how to describe the pain. All right, it's not radiating. Then she was having spotting since the past 1 day. So
Yes.
now there's nothing to. Had you told me bleeding, I would have asked you 10 more questions. That how much is the bleeding? How many pads soaked? And if she's having any fainting attack, or which you've already described. There's no passage of clots. There are no urinary complaints. Bowel motion is fine, and no history of what is that?
Vaginal discharge.
Okay. No history. Okay. No history of fever. And why did we ask about history of vaginal discharge or fever here?
Any history of any pelvic inflammatory disease associated with
Very good. Yes. Because pelvic inflammatory disease might also have pain in lower abdomen, spotting PV. These two things can definitely be there and could be just a delayed period. Why not? Yes. So PIDs also are DD, correct? And you've tried to delineate that. Okay. Yeah. History of present pregnancy.
the pregnancy is a spontaneous conception. Her urine pregnancy test was done at 50 days of amenorrhea at her home. She had not gone for any antenatal checkup till then.
Okay. Now, why is this history suddenly very important to me? Now we have confirmed. UPT confirms pregnancy. So
we will be thinking of any miscarriage or ectopic pregnancy.
Yeah, see, up till now, I just knew that it's amenorrhea 7 weeks. It might or might not be pregnancy. Suddenly, my mind is focusing on all causes of pregnancy. I'm slightly chucking off appendicitis, corpus luteal cyst, ovarian torsion, slightly more focused. And I've still not yet, kind of struck them completely. But I'm focusing more now on pregnancy-related causes. So glaringly, I can't miss ectopic. I cannot miss, threatened abortion. I cannot miss a normal, and then third in list will come a normal pregnancy, maybe a normal intrauterine pregnancy with some comorbidity. Could be a corpus luteal cyst, ovarian torsion, appendicitis, UTI, anything. Okay, so I'm prioritizing now. Suddenly, I have shifted. Up till now, see, this is what I was trying to tell you. When a case like this comes into your exam, suddenly you get very happy. Oh, it's ectopic pregnancy. Where the hell have I told you that she is pregnant up till now? You just know that amenorrhea is there. By the history of her, she's just told that I've not had periods, and suddenly I started having bleeding and pain. How are you thinking that she is pregnant and ectopic? Now that focus starts appearing suddenly. Now that you've confirmed that her UPT is positive. Okay, now it is definitely a pregnancy. Move on.
Her menstrual history. She attained menarche at 13 years. The cycles were regular for 4 days, for every 30 days. The flow is moderate flow, not associated with any dysmenorrhea or passage of cloud.
Yes. So suddenly that DD in my mind that, maybe it's a period which is overdue, slightly goes now lower and down in the list, because she usually has regular periods. She does not usually have dysmenorrhea. So it doesn't look like suddenly an overdue period. All that now she has a UPT confirmed. Okay. Positive pregnancy. Okay. Then.
Marriage history. She is married for 2 consanguineous marriage.
Mm-hmm. Now here, Pavitra, very important is the history of contraception. Why is it important?
Any intake of OC pills and
that will do what?
treatment.
Very good, very good. She's married since the past 2 years, and this is the first time she's getting married. This thing pregnant, is it?
Yes, ma'am.
So 2 years. How could she not get pregnant? What, she was taking something? Did you ask for this? There was a history of contraception.
Yes, ma'am.
No,
she is not taking any contraceptive pills, ma'am.
She was not taking contraceptive pill, but what was her mode of contraception?
No, ma'am. She had not taken any method of contraception for past.
Okay, so she was not getting pregnant by herself. I mean, was she cohabitating with a husband? Husband was not staying with her, or they were using. Sometimes they don't speak about condoms. Was it abstinence? Was it coitus interruptus? Lots of Indian women they go by doing coitus interruptus. Was she having that? So, anyways, why is all these things are important? Contraceptive history is very important. Otherwise, also in obstetric history, especially in such a case like this, that she's been married since the past 2 years and never got pregnant, and now that she's got pregnant, it's ectopic, or you're delineating an ectopic pregnancy. Can anyone please tell me, Pavitra, you don't tell me this, my students are going to tell me. Can you tell me why is contraceptive history important, especially in when you're delineating a case of ectopic pregnancy? Very good. Anita has already answered one, which is one of the risk factors for ectopic in your Foxy Focus. Copper T, if you're using, if she already has a copper T in situ, if there is a pregnancy at all, it usually is an ectopic pregnancy. That's number one. Number two, if she's taken E-pill, I-pill, those kind of pills, and she already had ovulation, then she usually ends up in a ectopic pregnancy. So hormonal pills, that's true, they kind of delay the tubal motility. It is correct. So these are the reasons why contraceptive history, especially in your case, becomes paramount importance. Okay, we need to add this. And later on, I'll tell you what no contraceptive used. Okay, next, past history. Yes.
Past history. She is not a known case of hypertensive, diabetic, congenital heart disease, thyroid disorder, seizure disorder, no history of any bleeding diagnosis. There is no history of any blood transfusion, no history of any previous surgery.
Now, tell me, I'll not write it down. First, you'll tell me what are the other important past histories specifically that I'd like to ask. This will give the examiner an idea that this girl knows her topic, and they will decrease a few Viva questions from you. Your history will give the answer. Pavitra, if you can answer, it's fine. Otherwise, my students, I'd like to ask them. Okay, Pavitra will be quiet. My students are going to answer this. What is important in past history specifically, which I need to know, I will add over here in a short while. But you guys will answer me, why am I finding the past history important apart from what she's already given me? Tubal surgery she has included. PID is a very good answer. What else? No history of ART. I've written that down. No marks for that. Endometriosis. Okay. Endometriosis, mostly the patients will not be able to tell you, but yeah, it's definitely an important part. But examiner is not going to take this nicely. Tell me anything else. Smoking will come in personal history, though it is also important. Yes. Genital TB, I'll take it. Okay, I'll take it, because usually the patients, they know in Indian subcontinent, and Indian subcontinent, it's important. So no PID, no history of PID or TB, genital TB. Okay. What else? Yes. Anything else, guys? Very important. One more very important thing. Previous tubal surgery, agreed. I think tubal surgery she's already used. Previous ectopic, very good, but our patient, she's the primate, so we can't ask her this again. Anything else? Anything else that's coming in your mind? Mostly these, okay? So there's no history of any PID, genital TB, no history of any contraception use, especially IUCD or any hormonal pills, no history of any tubal surgery, ART. These are all risk factors for your ectopic pregnancy. STDs, okay? Sexually transmitted infections. That I'll add over. STD is what I wanted to hear, but it's okay. PID can be substituted. All right. Now,